Hello everyone. Today we are going to talk about pediatric lung ultrasound. I hope you are excited as I am to reveal this lecture for you. I hope it's beneficial for you as we'll cover the basic levels. Image acquisition, and we start with which probe to choose for the lung ultrasound. The linear probe. It's my go-to probe. Higher frequencies, 8 to 12 megahertz. It has reduced penetration and it is excellent for assessing the chest wall and the pleural abnormalities within 4 to 5 centimeter of the transducer area. And the phased array probe with frequencies 1 to 6 megahertz, good penetration down to 25 centimeter, and it fits perfectly into the rib space with its small footprints. The curvilinear probe, it has a good penetration, 22 centimeter. It is good for viewing the deeper structures, and it is ideal for exploring the entire pleural surface. Transducer knobology. The transducer movements. We have 5 basic movements: sliding, fanning or tilting, rocking, rotation, and compression. Sliding movement involves the entire probe in a specific direction to find a better imaging window. Tilting the ultrasound probe involves moving the transducer from side to side along the short axis of the probe. And rocking, it's either towards or away from the probe indicator along the long axis. And then rotation. Rotating the ultrasound probe involves the transducer movement in a clockwise or counterclockwise direction along its central axis. And finally, compression, when putting downwards pressure on the probe to evaluate the compressibility of a structure or organ of interest. This is the transducer knob or the indicator that should be oriented towards the patient head in case of lung ultrasound. Scanning tips to get better images: use enough acoustic gel and optimize the position of the patient and remove any bandages. Choosing your presets. A lung preset should turn off various smoothing and artifact minimalization algorithm routinely used, since we depend on the artifact visualization and not a definite structure. Turn harmonic imaging off, reduce the dynamic range, and to highlighting lung sliding and B lines, use focal points at the pleural surface. Set your depth. Bring the area of interest to the middle third of the screen. Keep the lung parenchyma to about 3 times that of pleura if it is the focal point, and align the marker on the probe to the marker on the screen. The arrow at the top of the screen is the near field, and you can see we are using a curvilinear probe. The arrow at the bottom is the far field. When we orient the knob toward the patient's head, the arrow to the left is toward the patient's head, and the arrow to the right is toward the patient's feet. When the indicator is on the left of the screen, the patient's we can find the patient's lung, and to the right we are seeing the liver, and this bright area is the diaphragm. We scan each lung zone by what is called Vulpicelli lung scanning zone. There are 4 areas on each lung divided by 4 lines, 3 vertical and 1 transverse: the parasternal line, the anterior axillary line, the posterior axillary line, and the transverse line just below the nipple line. You can see that we are placing the patient on a supine position. The linear probe is oriented towards the patient's head, and we are scanning the 4 lung zones in upper, lower, lateral, lower, lateral, upper, 4 lung zones. The PLAPS point is a point on the ultrasound, the posterior and or lateral alveolar and or pleural syndrome at the intersection of the posterior axillary line and the rib space between the 10th and the 12th rib. The PLAPS point is most relevant for assessing the presence of pleural effusion or lung consolidation. Commenting on The lesion we see on ultrasound, or the terminology of the ultrasound, we have four basic areas here. The isoechoic is the one to the left. If they appear gray in comparison to the surrounding structure, hypoechoic if they appear dark, and hyperechoic if they appear bright, and finally anechoic if they appear black. What do I scan with lung ultrasound? What do you see with lung ultrasound? Actually, you see nothing. You cannot see structure, you only see artifacts, because it's well known that air is the enemy of ultrasound. Generally, we see bat wing sign, lung sliding, A lines, B lines, alveolar consolidation, or pleural effusion. Bat wing sign, when the ultrasound beam hits between two ribs, casting shadows behind them, and then we interrogate the area of the lung between them, and this is where we know that we are in the lung. The two ribs with the pleural line, they look like bat wing. First thing we notice, A lines. Those are repeated equidistance below the pleural lines. They look like different pleura. Those represents reverberation artifact when the ultrasound beam reflects back and forth between the reflector. The ultrasound transducer interprets the sound wave returning as deeper structures, since it took longer for the wave to return to the transducer, and the presence of A lines indicate normal lung aeration. A for aeration. The B lines. Those are vertical hyperechoic rays projecting from the pleural line down to the bottom of the screen. So they should have prerequisites to call them B lines. They should be straight, well defined. They start at the pleura and they must end at the bottom of the screen, about 12 centimeter depth. And they move with pleural sliding. They are normally less than 2 to 3 lines in the lung field when the lung is normal. The comet tail artifact, they are unlike the B lines. They do not reach the bottom of the screen, and their presence indicates that the visceral pleura is attached to the parietal pleura, excluding the presence of pneumothorax. The presence of B lines indicates the presence of fluid in the interlobuli septae. Generalized B lines represent interstitial syndrome that is similar to ground glass appearance on CT. They are present in congestive heart failure, interstitial lung disease, acute respiratory distress syndrome or ARDS, early pneumonia, and they may be focal. They are absent in pneumothorax. Differentiating B lines in pulmonary edema from that of interstitial pneumonia, of course we are referring to the context of the patient, but generally in pulmonary edema they are usually bilateral, they are homogeneous, the pleura is smooth, while in interstitial pneumonia they are bilateral, they are patchy with the presence of other signs indicating consolidation such as subpleural hypodensities, and the pleura is thickened and irregular. In this video clip, you can see B lines. They are large B lines, and the pleura over them does not look healthy. It is thickened and interrupted. In this video clip, you can find the B lines are patchy, and in this area here and this area over there, but this area of the lung does not have B lines. That is a normal area, while these areas, they have pneumonic patches, and the pleura here thickened and interrupted, also subpleural consolidation indicating pneumonia. Here is a footage of the lung, rib, another rib, shadows behind, two lung fields, and you can see the B lines are confluent. You cannot see the lung behind them. No A lines, and the pleura is thickened and interrupted. Usually this indicates severe pathology. Lung sliding. What is lung sliding? Lung sliding signifies the juxtaposition of the two pleural layers that move synchronously during breathing. They are visualized as shimmering lights or marching ants, best visualized on live and not stills images. Tricks for better visualization of lung sliding. Use linear probe. Adjust the depth to bring the pleura to the middle of the image. Decrease the gain. Lay the patient supine. best visualized at the second and the third intercostal space midclavicular line. Ensure the probe is perpendicular to the pleura. In this footage, you can appreciate the absence of lung sliding. There are no shimmering lights or marching ants. Also, absence of comet-tail artifact and the presence of A-lines. Those are signs of pneumothorax. Lung sliding can be detected using the M mode. In the M mode, you place the cursor over the pleural line. In the presence of lung sliding, you get image number A. The machine will display an image that is often referred to seashore sign or waves on a sandy beach. This stratified appearance is because of difference in movement between the chest wall versus the pleural line and the lung. If lung sliding is absent, as in image B, the mode will reflect an image of uniform horizontal straight lines. They are known as the stratosphere sign or the barcode sign. This is because the immobile pleura looks similar to the chest wall. While in image C, you get lung points where normal lung sliding here side by side to the absent lung sliding. Lung point is the intersection between the areas of lung sliding and the absence of lung sliding, and it represents the origin of pneumothorax. If you do a CT scan of the patient, here is where you place your probe to find the lung point, where this area has air in it, and it is area of pneumothorax, and this is normal lung with no pneumothorax between the two layers of the pleura. You can appreciate in this video clip the presence of lung points where there is an area of the presence of lung sliding adjacent to area of absent lung sliding, and by placing the M mode cursor you can get the barcode or the stratosphere sign. If you see absent lung sliding, it does not necessarily mean pneumothorax. We have a list of differential diagnoses. The presence of massive atelectasis, if you have mainstem intubation in a mechanically ventilated patient, or post-pleurodesis or apneic patient. Rule out pneumothorax with the presence of 3 signs: lung sliding, B lines, and lung pulse. Lung pulse are vertical stripes of sand along the seashore representing rhythmic movement of the pleura that is synchronous with the heart beats. Pleural effusion. You should comment on, are there signs of effusions? Is it simple or complex effusion? And if any, what is the volume of this fluid? Pleural effusion signs: spine sign, jellyfish sign, lung curtain sign, quad sign, hematocrit sign, and plankton sign. Using the curvilinear or phased array probe at the PLAPS area, in the area on the left, you can find that you cannot visualize the vertebral column past the diaphragm, while on the right, you can see the vertebral column here past the diaphragm. Of course, we can see pleural effusion here, but our emphasis here on the presence of vertebral column spine sign. The jellyfish sign. It occurs when a consolidated lung is seen floating in the pleural effusion. The lung curtain sign, a sonographic sign, its presence indicates the absence of pleural effusion. By asking the patient to take a deep breath, you can find the lung sweeping down across the screen. Quad sign, the pleural effusion has anechoic appearance, delineated by the visceral parietal pleura and the 2 rib shadows. Hematocrit sign refers to echogenic layering here of materials in pleural effusion. This can be an exudative effusion or hemothorax. Plankton sign shows an effusion with a swirling hyperechoic debris differentiating pleural effusion into transudative or exudative. In complex pleural effusion, the pleura is thick and there are hazy collection of internal echogenic coarse debris and echogenic foci indicating the presence of gas within the pleural cavity. In this footage here, complex pleural effusion, this is the pleura here, there, and that area over there is thickened, and you can find swirling echogenic debris. This is the plankton sign, and those fibrinous threads you can see here indicating the presence of loculation. If you want to estimate the volume of effusion, measure the distance from the inferior edge of the lung to the superior edge of the diaphragm. Multiplying them by 200, you can get the amount of effusion in milliliters. Consolidation pattern. Sonographic signs of consolidated lung, lung hepatization, dynamic air bronchogram in the hepatized lung, abnormal curtain sign, subpleural consolidation, and finally shred sign. Mirror image artifact. It is a normal finding that occurs when reflection from a structure creates a false image behind a reflective object, such as the diaphragm. When you look at the left of the screen, you think it's another liver, while in fact it is a mirror image of the liver. In this video clip, you can see a hepatized lung over there, and here is the liver, here is the diaphragm, here is the hepatized lung, and in this area you can see here those horizontal hyperechoic lines representing the air bronchogram that we will come to later. The second sign here is the shred sign. It's a fractal sign, a static sonographic sign of lung consolidation, when the consolidated lung tissue appears as subpleural hypoechoic region that has an irregular shredded deep border, the fractal line, and this brightness is because of the air that scatters the ultrasound beam. Dynamic air bronchogram. They are linear hyperechoic lines that are present in the consolidated lung. Dynamic air bronchogram when there is pneumonia, and distinguishing it from static air bronchogram that is present in atelectasis. You can see multiple areas over here, over there. Those are mobile air bronchogram. Subpleural consolidation. This area over here, you see a hypodense area below the pleura that is shredded. You can see also B lines and absent of A lines. That indicates consolidation. In this image, you can see a large subpleural consolidation digging deeper into the lung parenchyma in case of more severe lung pathology. Thank you for listening.